Thanks. It's really an honor to be here, and thank you for the invitation. To echo Dr. Thompson's previous comment, this is really going to be something different than the last couple of days. When I was thinking about the talk, I wanted to try and get some topics that would be of a broader interest and yet demonstrate how imaging is impacting on medicine in a broader scope. So hopefully I can convey that today, that it's been a broad topic and it's getting deeper. Just quickly to look at kind of the history of medical imaging, it really started in 1895 with the discovery of X-rays by Röntgen. And interestingly enough, Röntgen was a basic scientist, a physicist, but within 2 weeks of discovering X-rays, he was a radiologist. He had taken an image of his wife's hand. So it's pretty phenomenal to think that within a matter of 14 days between the discovery of X-rays, they were being used for medical imaging. And then there was really a gap of about 50 years where there wasn't a significant technology addition to that armamentarium. And then there was a plethora of new technologies. Ultrasound was introduced in the 50s, and that was, of course, an offshoot of the development of sonar for World War II. Likewise, the development of the atomic bomb created cyclotrons and reactors capable of generating large amounts of radioisotopes and ultimately used for medical purposes. And then really the significant or most significant advances came in the 70s with the introduction of computed tomography, and in the 80s with the introduction of magnetic resonance imaging. And then to some degree, as you've seen here, particularly with respect to cancer, was the introduction of positron emission tomography, which is really just a particular way of doing nuclear imaging in the 90s. But it was really CT and MR that have changed, in fact, the face of medicine, not just imaging. And there have been several surveys of physicians about what technologies impacted medicine the most over the last century or half century. And CT and MR are either at the top or right behind penicillin, because they really did change the way medicine was practiced. For the older folks here, you'll remember Dr. Kildare. I kind of barely remember him, but he was a surgeon on a TV show. And I'll never forget, the patient comes in the ER, they've got a stomach ache, and they can't figure out what's going on, and Dr. Kildare is going to do exploratory surgery. Well, there's no surgeon in their right mind that would do that today. If they don't have a CT or an MR, they're not going to open the patient up. So it had a paradigm change on how patients were managed. And just to kind of give you a little bit of a taste of the breadth of what these different types of images look like, here's just a regular projection radiograph of a chest. These are probably the most done, numerically the most performed procedures. They're done routinely for screening for tuberculosis, for screening for other lung diseases, done all the time. This is an ultrasound of the prostate. Ultrasound is another, of course, all are non-invasive, but it has a totally different kind of appearance and has a different contrast mechanism. And it's very hard to read, in my opinion. And then once we get to CT, you can really appreciate the fact that CT is three-dimensional, so you're really looking at a slice of tissue, so that gives it a significantly different contrast characteristics relative to the X-ray, and it really begins to show the anatomical relationships between organs with a very high degree of spatial resolution. Then MRI, like CT, is tomographic, so it really is inherently three-dimensional. You're looking at the projection of a slice of tissue. And the big difference between MR and CT, well, there's two big differences. One is there's no radiation with MR, but the bigger difference is you can really begin to see differences in soft tissue contrast based on the chemical environment of the protons, the water protons, in those tissues that you don't get in CT. And then finally, nuclear imaging, and in fact, this is a PET image, is very different where you don't have really good resolution, but you begin to see function. And so you can find lesions. They're typically used more for screening, looking for distant metastasis when we already know where the primary is, because now we can find that distant metastasis pretty easily because it pops up out of the background. So today, kind of where are we? Well, you know, the vast majority of clinical medical imaging today continues to be all about anatomy. We're trying to understand the anatomical situation, whether it's a heart anomaly, whether it's a cancer, is it getting bigger, smaller, is it invading a different structure? So it's really about anatomy, although a lot of the research today is beginning to be more focused on adding functional capabilities and not just improving the spatial contrast resolution, but how can we add function to that anatomic data? And probably in the last 20 years, what we've really seen is a leveraging in those technologies that have been around for a while, but now the electronics and the computation speed is continuing to go up exponentially. Thank you for cell phones, gaming, high-performance computing. We've now gone back and been able to revisit a lot of the computational background for reconstructing images that just wasn't possible in the past because of time. In fact, I can remember we got the first MR scanner, or the fourth MR scanner at the University of Kentucky. It took 20 minutes to acquire one image, just to acquire the data, but it took 40 minutes to actually compute a very low resolution data. So you would acquire the data and you didn't have the study until the next day or late that afternoon for the radiologist to look at. Now we acquire thousands of images in a matter of minutes and they're reconstructed on the fly. And then the sequencing of the human genome has really created the possibility of imaging molecular targets. And that's a whole separate discussion, I think, from what I'm going to talk about today, which is really more about the physics and that aspect. But it's certainly a hot topic that we're trying to understand how we exploit it. So I'm going to talk, again, mainly about MR here, and why is MR unique? Well, MR is unique because it really kind of spans the scope of possibilities of types of images that can be acquired. So you can see that, let me see if I can figure out you can acquire just a regular anatomic image, and this is a pretty high resolution. And oh, by the way, you probably figured out that's not a human, right? So that's the image, or this is an image of a mouse brain, okay? So those familiar with mice, you know, we're talking about a 20-gram animal, so that the brain on this animal is, you know, much smaller than the end of your finger. So we're able to achieve, you know, very high resolution even in animals like that, but you also see this soft tissue contrast. Here's another image of a orthotopic bladder cancer in an animal. Very difficult to assess how that tumor is growing or responding to therapy unless you can image it volumetrically. So this is a very good research tool. We can also use MR. These images show the temporal uptake of an intravenously administered contrast agent, which, based on the characteristics of that signal intensity with time, you can plug them into these pharmacokinetic models to then come up with characteristics of the microvasculature with respect to time, looking at either how's a tumor evolving with respect to its angiogenic properties, or of course there was a significant interest in using anti-angiogenic therapies in the 2000s, so we could look at how our tumors responding to those anti-angiogenic therapies using MRI. And then this is just an example of how we can also do fast imaging with MR, even on a very small scale. And again, this is a mouse, okay? So one, the heart's about the size of a kidney bean, and it's beating 300 beats a minute. But yet we're able to image that organ moving and look at the function in terms of the ejection of blood from the organ at that temporal speed. So it's a very robust modality. Kind of to go back to this, why do we want to worry about function now? If you look at this image, it kind of represents the challenge the radiologist often has, which is looking for a needle in a haystack, or in this case, a leopard in a grass field. So how many people see the leopard? Okay, well, it's kind of hard. When you look at, if you just have the optical information, it's kind of hard. If I had an infrared image, you would immediately pick out the leopard out of this scene. Now, you may not know whether it's a leopard or a tiger or a dog or whatever, but you would pick out that leopard pretty quickly in an infrared image. So merging an infrared image with a visible image, you would quickly see that there is an animal there and it's the leopard, and you better get the heck away from that guy. So this is kind of the challenge with imaging, is how do you find that leopard, which is analogous to a tumor, which is very good at hiding itself in a background of normal tissue. So just to kind of review the current research areas and then why I've picked the two that I have to talk about for MR, there's a significant amount of work going into quantitating and functionalizing the image data. So 99% of the image data is interpreted by radiologists. They verbally dictate a report that's qualitative, and there's no quantitative data. So there's a lot of work going into how do we quantify what the radiologist sees in terms of the image characteristics, the tumor size, the textures. These are all very challenging to quantify computationally. And it's not that the computational aspect is the biggest challenge, is how do you characterize what the human visual system is perceiving and then translating into that report. Metabolic imaging has gotten to be a very hot topic recently, especially with the emphasis on understanding how genomic anomalies affect metabolic phenotypes in tumors. Again, molecular imaging is an area where we want to be able to image these molecular characteristics of cells, particularly cancer cells. Image-guided therapy, we're beginning to use the imaging technologies to guide therapies, whether it's surgery, intervention, radiation therapy is almost entirely done on image-based now. Earlier detection, looking at technologies that can allow us, as Dr. Thompson was alluding to earlier, how do we push the detection of disease earlier, which we know is going to result in better treatment outcomes. And then finally, how do we link these different imaging characteristics into the genomics and these big data databases. So I'm going to talk about how MR is playing a role in metabolic imaging and image-guided therapy over the next 15 or 20 minutes or so. And you've seen these diagrams from Hanahan and Weinberg looking at the hallmarks of cancer. So when we kind of think about, well, where can imaging play a role in that? We spent a lot of time in the late 90s, 2000s, again, trying to create imaging approaches, particularly with MR, but also with CT, that would look at the induction of angiogenesis as part of the cancer evolution, and then the response of tumors to these different angiogenic therapies. But then in 2011, the Hanahan-Weinberg hallmarks got expanded to include immune destruction, inflammation, genetic instabilities. And interestingly, this is kind of where, at least for me as a physicist, I began to really appreciate the cellular dynamics and metabolism were going to be really important in understanding how we were affecting tumors with all the different strategies that were being introduced, especially in the precision medicine, where you would maybe just hit one pathway, and was that target actually having an impact on the cell's metabolism? And then Anwar Padani had just prior to that looked at kind of what were some of the imaging opportunities for looking at these different hallmarks, and you could see that. I'm sorry, I lost my pointer. When we get over here to alter metabolism, there were some different approaches, whether it was using positron emission tomography, MRI, or other PET agents. But one that was very interesting, and it's evolved quickly, is the ability to detect carbon-13 and study that metabolism in vivo. Why is carbon-13 interesting? Well, if we look at this table of MR visible nuclei, so these are nucleuses that have MR properties so that we can observe their characteristics. When you get down to carbon-13, you can see that there are a number of very interesting metabolic products. And in fact, that's probably 90% or 95% of high resolution in vivo NMR chemistry is looking at carbon-based chemistry. The challenge with carbon, of course, is this relative sensitivity. So if we look at the relative frequency of the nucleus, so if you put this nucleus in a big magnet, what's its resonance frequency? And that to some degree is going to tell you what its signal strength is. And then you look at the relative abundance of that nuclei, of all the nuclei for that atom. When you get down to carbon, the problem is it's 0.01% relative to protons. Okay, so you're 4 orders of magnitude less sensitive looking at carbon than you are protons. Well, again, in glassware, in a high-resolution NMR scanner, you can enhance, you can enrich, you can put your sample in and scan for days, and you can do these really eloquent analysis, but you're not going to be able to do that in vivo with that kind of sensitivity. However, every once in a while, a sentinel event happens. In the early 2000s, the group of Klaus Goldman at Amersham in Malmo were working on how to exploit a phenomena that had been known for a while, which was this what's called hyperpolarization. So it was known that there were ways that you could polarize nuclei under certain conditions that would make them have much higher signals. In other words, you could get the spin states to be much further apart when they're excited so that when they relax back, you can detect this signal. They figured out a way of packing carbon nuclei in a solid with dopants that had electron donor characteristics such that if you took these samples down to almost 0 degree Kelvin in a large magnetic field and bombarded them with microwaves, you could excite the electrons, which would then transfer the spins to the nucleus. And so you could then make those nuclei look like they were in fields that were unachievable in nature, but created this polarization that instead of being parts per million was now fractions. 30, 40, 50% of the protons would be affected by this polarization. So again, you had to do this in a very sophisticated instrument that they came up with that was I think theirs was actually a 3.3 T magnet. They had a helium vessel that they could put their sample down into, get near to 0 degree K, bombard it, and then create a hyperpolarized compound that, when dissolved back into a liquid state, retained its hyperpolarization long enough to be detected. And that's the real trick. So here's just an example of how much amplification you get. So this is a sample of urea that's going to be our standard. So this is 5 milliliters of 8 molar urea. Believe it or not, embedded in here is a 1 milliliter sample of pyruvate at 20 millimolar. And you can't see it because under just thermal equilibrium detection, there's just not enough signal. You can't even pull out noise. However, if you hyperpolarize it, this is what this signal becomes to look like. Okay, so it's, it's 10 or 100 times bigger, the signal is, and you have to remember that the number of carbon in this sample is about 1/100th of what's in that sample. Okay, so it just demonstrates you can really see this huge signal amplification. In fact, it's more like 30 to 50,000 times in practice. This, excuse me, this was interesting enough that at the NCI Director Day, when all the branch folks come in and give their little poster presentations, 2 years ago, the branch chief of the cancer imaging branch had this as their new technology that could be a game changer in cancer. It was really about the ability to polarize these nuclei and then observe in vivo carbon metabolism was the cancer imaging branch's high priority for 2012. So why pyruvate? Well, it's fundamental to metabolism, has rapid pharmacokinetics, and then here's the big kicker, there's no free lunch. It has the carbon in pyruvate has a relatively long half-life. So once it's polarized, brought back to room temperature in a liquid state, it actually persists for a few minutes, okay? The challenge with many many carbon centers in different chemical domains is that they have uber fast relaxation. So you can dissolve them back into, you can do the chemistry, get them into a compound, but within microseconds they're gone. They relax back. So the advantage of the pyruvate is that it stays long enough that you could inject the pyruvate, have it metabolized, and still observe the original pyruvate and the metabolites. And of course, in cancers, many have upregulated aerobic glycolysis, and so knowing what that metabolic state of the tumor is can be very important in how we assess its state or treat it. And so you can look at because it's a spectroscopic technique, you can see the different peaks for pyruvate, alanine lactate, or bicarbonate, which are the precursor and the end products of this metabolic pathway. So I'm not going to go into that too much. I want to show a couple of examples of work we've done in preclinical at Anderson. We've got one of these polarizers. We've been working with Stephen Lai's team and some others. And just to show that in vivo, we are able to monitor changes in metabolism after therapeutic interventions. So these are in different mouse models. This is an endothyroid carcinoma. You can see there's differences in what the lactate production is depending on the treatment. Here's a different set of experiments where we were looking for changes in metabolism with respect to radiation therapy. This is something that we've been looking for a while, but the measuring this in vivo is hard because of the rapidness which it happens, but we were able to show that there are immediate changes in pyruvate metabolism after different doses of radiation. And then with Mong Hong Lee's group, recently Jim Bankson and had been working with Mong Hong to show that this suppressor gene 1433S interacts with the glycolytic enzymes through MYC, and you can use this imaging to estimate the changes in the metabolic characteristics based on the expression of the gene. So we're actually able to kind of link gene expression to in vivo metabolism using this technology. It's now evolved into a clinical system, so it's gone from for the engineers in the group, it's gone from a design that has all of the polarizing part, but also has to do all the chemistry, in line, because you only have a few minutes between the time you create the compound and when it's going to go away. You've got to get this all through. You have to get it prepared for injection into a human. So there's a significant amount of chemistry that takes place as well as testing. And this system is called the Spin Lab, and it's now sold by General Electric. It's not a cheap system, but it does all of that in a self-contained system that's now it's FDA approved for testing. And there are about 15 of these systems, and we've just purchased one to get into the game. But just to show, the first study came out of UCSF August of last year, and they did 33 patients, and this was just a safety study. So they've collected a bunch of data, but they really have just reported on the safety. And they were able to show that you could administer these agents and follow them in vivo in prostate, and there's a reason for prostate because the pyruvate metabolism in prostate is of interest, and it's very different in tumors. So you can see again, it's nuclear medicine kind of. It's low spatial resolution, but it's showing it that there's activity. I want to give one example of a finding that was very interesting. Again, here's just the kind of the details on the patient. So these were all patients that had known biopsy-proven cancer. But back to Dr. Thompson's point, this patient had a biopsy-proven cancer, which was this one. When they did the study, you see that this one lights up as expected, but there was another lesion on the other side. They went back and rebiopsied and found out that in fact was cancer. Now, that's significant. Again, this falls into Dr. Thompson's discussion. Is this an active tumor is a big question, okay? Well, this certainly showed that was active tumor, and you can really kind of see it in this anatomic image. This also told us that there was a secondly active lesion in that gland. Now, again, we're not sure quite what that means, but it probably means it's a more aggressive disease. And the other aspect is, as we're thinking about at least partial gland therapies, which are attractive because they think the mortality will be lower, will preserve function better. If you had gone and done a half gland therapy here, you would have missed this entire tumor. So knowing where that tumor is important in how the patient gets managed. Just to conclude this part, it's a big team science project so far. And again, at Anderson, we've really just done the preclinical. We're just now getting into the clinical. But it includes folks from the physics team just trying to get these things to work, get the kinetics going, do some modeling on how we analyze the data. Lots of other Anderson collaborators. We have two chemists that we're working with, looking at other tracers, if you will. Lots of other basic scientists and clinicians. We've got a CPRIT grant, in fact, with Dean Sherry, Craig Malloy, and Matt Merritt from UT Southwestern to develop. We're kind of working on some of the technical approaches. Dean and those guys are working more on some new molecules. And there's been quite a bit of funding from the P30 and U24. Then we'll switch gears and talk about image-guided therapy for the last few minutes here. And traditionally, we've used imaging guidance as kind of a passive guidance using either fluoroscopy, ultrasound, and recently CT. But we've really started to spend a lot of effort trying to get MR to be an image guidance technology. One, it's got no radiation, which is like ultrasound, which is good because these procedures often take a long time. The highest radiation doses of staff in the hospital are interventional radiology, by far. Okay? So using a technology that it doesn't expose the patient or the staff to radiation is good. Another advantage of MR, like ultrasound, is you can image oblique planes, any arbitrary double oblique, so you can image exactly where you want to see. And there are multiple contrast mechanisms, so if we're either looking at soft tissue anatomy, or as I mentioned, we can start folding in these functional properties, whether it's vascular properties, or maybe, I'll show you a little bit later, some other kinds of functional. And then we can also measure temperature, in fact, with MR. So as we start looking at some potential MR-guided thermal therapies, this was a big advantage. So about 6 years ago, we actually put an MR scanner into a neurosurgical suite. And yeah, it doesn't sound like a big deal, but if you think about, you put a 1.5 Tesla magnet into a room full of sharp objects, sharp ferrous objects, there were a lot of technical issues and safety issues that we had to get through. But even beyond that, there were a lot of, how do we integrate this data into a way that enhances the surgical procedure so that the surgeon can benefit from having the MR scanner in the room to facilitate doing different kinds of surgery. So we spent a lot of time working on, what data do you want, how do you want it presented. Jeff Weinbergs, who's one of the neurosurgeons, was leading the effort. Ed Jackson from our group was working with him. You can see all these different kinds of MR data. Whether these are called tractograms, so they're ways that we've tracked the fibers in the brain, just shown in color here. These are functional, what we call functional MRI, and it's actually imaging, this is a motor strip. So we've had a patient tap in their finger, and we're able to see on the brain where the active center for that function is. And so the surgeons want to take out as much tumor as they can and leave as much function as possible. And so we're also able to map that either onto electrodes, where the electrodes are on the brain or on the surface. And what that allows the surgeons to do is to start out with these pre-surgical images. And you could easily see, big tumor there. So the surgeon goes in, based on all this data, they've integrated, they'll do their surgery, and then they actually put the patient in the scanner and rescan them during the middle of surgery. And you can see here, in this case, they missed some of the lesion. And the problem is, as they're debulking this lesion, all the anatomy's changing, okay? So, you look at it and go, why don't they scoop the whole thing out? Well, they're taking it out, and everything's changing. And they're wanting to, again, preserve function. So they're trying to cut out as little or as much as they can without affecting function. And then, so they went back and they did a little more surgery based on this, and they were able to get a pretty clean margin on that. There's just a little bit of edema, which is probably not disease. We also want to use this technique or this technology in interventional radiology where speed is critical. So we want to be able to track devices in real time and get them targeted to locations that we may only be able to see with MR. This is a lipoma that you can actually see very easily on the MR. It's very hard to see on CT, but you can see this device being inserted in here, and they're going to do a core biopsy. So we can use this to guide that. We've done a lot of work looking at different applications. The interventional radiologists have a whole different set of new tools that they use that all have to be developed to be MR compatible. And so they've developed some different approaches. Here's a different way that they were doing bone biopsies for I think it's a sarcoma. Steve McCrae is another interventional radiologist, and based on some prostate imaging data, he began to think that he could detect these functional locations better for biopsies, and interestingly enough, decided that the best approach was transgluteal. So he's able to do this much longer approach, which has to cross less critical structures, but before they were reluctant to try this approach because the needles bend over that distance. And so it was hard for the interventionalists to stay on track. You know, it was easier to go the short distance than the long distance. So to be able to visualize this all in real time gives them a lot more confidence, and they're able to hit their target better. And that's a significant issue when you want to make sure that your biopsy has gotten the suspicious disease out, not just some part of the tumor. We also, because MR can image temperature, we really got interested a few years ago in looking at, can we use MRI to guide these thermal ablative therapies. Thermal ablation has been tried for a long, long time. The challenge is in the anatomy, the physiology tends to make it difficult to predict how big your heating bloom or your ice ball is going to be in cryotherapy. But with MRI, we're actually able to image temperature in real time. When I say real time, I mean every few seconds, and then add up a thermal dose. So what you're seeing here is, this is the whole setup for how we get ready for a procedure. And then there's a laser fiber in here. And so you're seeing the temperature evolve here, and then the accumulated thermal dose there. And it's the accumulated thermal dose that's going to predict what the kill zone is. So we worked with a little local company here, Biotech. It's now Visualaze. They've pulled out the marketing for this system. They had developed some water-cooled laser fibers that allowed them to put enough energy in to do a relatively large ablation, but they needed to build a system around it so that you could control the lasers with the MRI feedback. And so we worked with them on several SBIR grants to develop this system called Visualaze. It's got a nice little interface so the radiologist or the surgeon can sit there and watch the temperature evolve while they manage the laser output. As usual, I think it's been mentioned here a couple times, the FDA makes it difficult to do these kinds of studies in the States. So we went to Paris with them, and Alex Carpentier, the neurosurgeon, did the first 70 patients in Paris with no adverse reactions. And you can see that we were really able to measure this temperature, the thermal dose. It's kind of hard to see on this here, but this is actually images immediately after the therapy. And this little rim of enhancement is very typical of the zone around the ablation that's not quite ablated, but is damaged enough that it's going to die. So it's a great indicator, especially in brain, of what your kill zone is going to be. So you can guide your therapy, you can guide the placement of the laser fiber, you can then monitor the therapy in vivo, and then you can assess how well you did immediately after the therapy. We also worked with Naomi Hallis and Jennifer West from Rice. I don't know, Naomi was here yesterday, but looking at using gold nanoshells to try and enhance that thermal distribution. And the idea is that we would create enhancement based on the physiology or the biology of the tumor. So we know that these nanoshells cross the leaky vasculature in a tumor more than they do in the normal tissue, so they'll tend to just physiologically accumulate even without biological targeting. This is a movie of the first mouse that we did with an IV injection of nanoshells. So we injected the shells, we waited 12 hours, we've shown a laser on this tumor and we've shown a laser on that tumor. This one, no shells, this shells, and you can see that where the tumor was that had shells administered IV, you got ablative levels of heat. So we were able to show that, we can use these shells as enhancers of the light energy that's being deposited, and we can monitor that in real time in vivo. And of course, we craft these shells, Naomi crafts the shells in a way that they absorb highly in this what's called the water window for near infrared light. So the near-infrared light penetrates the tissue very well, but then gets absorbed by the shells, and the absorption of that energy causes heating. So we did a lot of experiments in larger animals just to demonstrate that it would work. So here's in a dog brain. We used a fiber on this side. There's no tumor here. There's a transmissible venereal tumor here that takes up the shells. Administer them IV, wait a day or 12 hours. Both of these lasers are going at the same power, so you can see there's a little bit of heating here, but not much, whereas in the area where the shells were in the tumor, you get a lot of heating. So the normal tissue may go up a few degrees, and you get significant heating where the tumor is. We worked with Dr. Oden and Yuxing Feng, Ken Diller on a project looking at how we can better control the lasers using modeling on high-performance computing that was in Austin. So we actually were acquiring real-time MR image data in the basement of MD Anderson, transmitting the data to Austin, doing computational modeling of how the temperature is how the heating is expected to go, and we could then manipulate the power to the laser to try and to achieve a desired heating pattern in real time based on a priori knowledge of what the anatomy and physiology was going to be. And just to summarize, this really is a big team science project. You can see we've got a whole group from imaging physics. We've got neuroradiologists, radiation oncologists, interventional radiologists, neurosurgeons, veterinary medicine, Rice, UT, computational. It's a very, very broad area. These are just now going through trials with the shells and without, looking very promising, and it's really going to be up to the surgeons to decide how well those are going to get into practice. So that was all I had, just to give you a flavor of what's going on in imaging, and if there's any questions, I'd be happy to answer.
You mentioned you did some studies of the safety of MR. Was it just the flying instruments that were attracted by the magnet, or the magnetic field on the brain? Well,
so the answer is the magnetic field interaction with biological tissues. People have tried to find any kind of correlation with almost any kind of biological effect, and it's just, it's hard to say it's not there when none of the experiments have shown any effect. So that's not really the challenge. The challenge is just the ferromagnetic objects. There's also some concern about heating depending on the RF energy that's being put in, especially if there are other devices in the body that might act like antennas. The body normally doesn't act enough like an antenna to absorb enough of that energy to heat, but if there are electrodes or other kinds of material in there, then yeah, you get concerned about it.
Yeah, just the carelessness of having metal objects around. We had a workman have a metal toolbox jerked out of his hand, right, and slammed into our machine.
Yeah, well, that's your biggest safety issue in MR is flying objects.
Is the computational power reached the point where you can do real-time MRI routinely now, or is that still a limitation?
So it's becoming more and more routine. And again, it goes back to the electronics that are available for the gradient systems, and the data acquisition systems have gotten fast enough that we can do some of the acquisitions that we couldn't do a few years ago. And then on the computational side, to be able to recon the images fast enough. And then if you need to do any comparisons where any of the mathematics, it's all doable now. That's not an issue like it was even 10 years ago. So that's pretty resolved. And it really becomes, there's always a trade-off when you go faster between spatial and contrast resolution. So it's really about what do you need to see at what resolution is going to kind of determine how fast you can really go. But we can acquire MR images with reasonable contrast and reasonable spatial resolution in 300 microseconds. Thanks.